UCLPartners Opioid Network meeting. I'm Jessica Town, and I'm an implementation manager at UCLPartners, and I'm the work stream lead for the Medicine Safety Improvement Program, or MedSIP as it's called. So just a bit of housekeeping while you have a look at the agenda. You're very welcome to turn your cameras on, but please do keep yourself on mute unless you're speaking, just to minimize the background noise. Do feel free to raise your hand or put any questions in the chat. I'll do my best to keep an eye on it. And if you are speaking, please do try and either avoid acronyms or spell them out when you use them, just to make the discussion inclusive for everyone on the call. And it's now my pleasure to introduce our guest speaker, Shivani Patel, who is the lead clinical pharmacist at the Haringey GP Federation. Shivani is going to be sharing some of the work that they've been doing on reducing opioids for chronic pain in primary care in Haringey. So please take it away, Shivani.
Okay, so a little bit of background as to what we did and why we did it in Haringey. Actually, every sort of quarter we receive updates from the medicines management team, which highlights our prescribing patterns. It doesn't just focus on medicines of dependence, but actually it's something that helps us to see strategically what are areas which require, some interest really. So we had a local need to focus on opiate prescribing. This is the most recent data that we've had, but actually contractually on the DES contract for primary care to deliver on, opiate prescribing has been a priority. So we thought we'd have a bit of a spotlight focus on opiate prescribing. Next slide, please. So some of our aims were to make sure that the work is prioritized proactively as well as reactively, to increase the number of structured medication reviews through the year, and to upskill the pharmacy team to support this cohort of patients. And below is some of the ways of how we did it. So we ensured constant stakeholder engagement, and this included quarterly performance data being shared with the pharmacy team, and also reported back to PCNs, and making sure we had tools and tips on how to conduct the work alongside the business as usual medication reviews. We also try to make sure we're motivating the team to prioritize the work, and also spotlight practices with particularly poor data. And it's not to bully them out of it, but more to highlight the size of the problem. We also made sure that the content was built into our ongoing education and training agenda, so that pharmacists felt skilled to actually conduct the work. So if I can have the next slide, please. So these are some of the standards set. We looked at NICE recommendations and CQC as well. They don't actually quantify how many patients or percent practices should be aimed at. However, they state it as best practice. So what we decided to do is not to set a standard, however, make it a bit of a realistic sort of target. So we did look at about 50%, and we weren't confident, in all honesty, that we'd get there, only because of competing priorities. And some of the other challenges included a lack of protected time towards this piece of work within the borough, but also recruitment and retention issues for primary care pharmacy. The other thing to note is also the fact that some of our pharmacists were new to primary care and junior in their role, and there was a bit of a hesitance to take on this piece of work, understandably due to competence. So if we can have the next slide, please. So we did some scoping work where we used surveys to understand, and again, this was shared sort of broadly within Haringey through our informal networks. We also have a practice managers forum and a PCN CD board forums where we've shared these surveys and received responses, specifically focusing on opioids. So I won't bore you with all the content on the slides. However, it focused on people's perception on why we think there's an overuse of opioids in chronic pain and why that might have increased. We got a view from clinicians and patients. What can we do in primary care really? And why do we need to do this, as well as any barriers? So I think something that stands out was the fact that there's a lack of sort of funding and services specifically focusing on this piece of work, more so the reduction of opioids rather than going to a typical pain clinic and sometimes having lots of painkillers added on. So these were some of the outcomes through the 4 quarters that we had last financial year. We focused on 2 separate areas, and this was looking at combination prescribing, so looking at the gabapentinoids and benzos with opioids as well as Z drugs. And then the separate cohort we looked at was opioids equivalent to 120 milligrams morphine or more. So the Q1 data is effectively our baseline. And it shows where we've highlighted green in Q2, it shows we had an improvement. The red along the tapentadol is no improvement, but I guess luckily we had 0% at that point. So you can see actually the one patient on tapentadol in Q1 wasn't actually on the high dose anymore. We didn't repeat the SMR essentially. So it's not as simple as we've got some numbers to show increased sort of SMRs. If we think about the final sort of outcome at Q4, we didn't reach the 50% ambition. However, we did have a very broad ambition and we didn't separate that out to the different cohorts looked at. So we can see most our pre-CNs and practices reached around the 35% mark, especially for the top indicator looking at the combinations. And the second one, we've had a lot of variation really. Can I have the next slide, please? And this is looking at the overall SMR performance. So this was really to highlight that although we have a focus on the opiates and addictive medicines, actually a lot of other work was going on in the background. So we had SMRs looking at frailty, care homes, other medicines associated with harm, predominantly looking at NSAIDs, polypharmacy and long-term conditions, which you can see takes up most of the clinical pharmacist's times. And in total, we had just above 10,000 SMRs in the last year. This is looking at current practice. So we're now moving away from a spotlight focus on opioids specifically and thinking about treating it as business as usual. So this shows a Q1 report, which was pulled up from last week, actually, so relatively fresh data. And we can see actually, again, there's variation across the different PCNs, but it does show that some of the work has kind of continued. Now, initially, when I looked at this data, I thought, oh no, this isn't looking very great. And it only captures SMRs picked up from April. So it's still the new SMRs looking at this fiscal year specifically. But actually, if we extrapolate to what this level of drive looks at towards the end of the year, we're looking at almost sustaining the practice. And just to note, the search criteria is a little bit different where abuse potential covers all the abuse potential drugs and doesn't separate out from combination or not. I think that was it for my slides. And I guess the purpose of me coming today was to share our methodology and ideas, of course, take some ideas to how to improve this work and sustain it, and just thoughts and comments really. So Jess, I think I can open up the floor for any thoughts, comments or questions. Thank you.
Hiya, sorry, what does SMR stand for? Is my first question.
Sorry, I should have broken that down. It's a structured medication review. So the idea is it's a more detailed review of the medicines, the reason why it's prescribed, is it appropriate, and looking at really optimizing it. So in the case of opioids, of course, reducing it, etc.
And then thank you. So then my next question was going to be in terms of what kind of interventions were being done in terms of some of that reducing the medication. So in terms of my background, I'm Vicky Dunlop, I'm Bowes service manager. So we're a de-prescribing service in Islington, very much looking at the medications that you've mentioned in terms of benzos, opiates, gabapentinoids and Z drugs. And it being that obviously, as you're saying, there is a lot of kind of crossover in terms of the polypharmacy as well as the kind of frailty and the long-term conditions. So I suppose I'm coming at it from a nursing background, and the other person within the team is from a doctor perspective. So I suppose it's just thinking about what your team of, I'm assuming all of this is pharmacists that are doing the reviews. So I suppose it's just thinking about what interventions have kind of worked from your side.
I think what we would have liked is to capture exactly how many reductions and stopping really, but I think realistically that's not possible given the amount of work that's required behind that. So effectively all we've monitored is the number of structured medication reviews with the hope that actually the education, the training and the tools is sufficient to reduce things at scale in primary care, given that there isn't an expertise in this area. So of course there's limitations of the quality of the data. It's specifically just on quantity, but we're hoping that does spotlight the reduction. And actually the way to truly measure it is comparing the prescribing data that comes along. I mean, I'm happy to look at it and sort of share that. But yeah, it was really just spotlighting this work needs to be done continually and not just when it pops up on an incentive scheme.
Julia, would you like to come in?
Thank you. Going back to the SMRs, so you just count the number of structured medication reviews the patient has. Is that what that data was?
Exactly.
Okay, lovely. Is there any chance of, because it looked fascinating and I'd love to sit down and look at the numbers, but it always passed a bit fast. Is it possible to have your slides so I can have a look at that?
Yeah, I'd be happy. Jess, you've got a copy of them, so please do feel free to disseminate them.
Thank you. That's very kind of you. It looks really interesting work. Sorry, my name's Julia Cambizzi and I do opioid reduction in chronic outpatients at UCLH. And Victoria, I think we share a few patients in common. Yes. Thank you.
I'm a PPI member. My name is Mahabuba. So just want to ask a question, like you say, reduction done. Did you check that one after that, as I got an ongoing health condition as well, and I'm using opioids. So after opioids reduction done, is it the patient come back or is it just reduction done for that time and then prescribe again? Did you check that one as well, the data, or it just totally reduction?
It's just looking at the total reduction, so it's difficult to get people to follow up. I think again this is another limitation, that this data relies on pharmacists putting in codes, so it could be that there is underreporting of the work, but this is what we've had fed back. But you're right, we haven't captured the number of follow-ups as a result, and actually the education and training very much focused on continual follow-up, and not just a one-off reduction.
Yeah, because why I'm saying, because sometimes a GP just take it off the medication for some days or give different medication. So how is ongoing to see check that one? So might be is not accurate in that side. Sorry.
Yeah, so no, it's a fair point, and I think this is where again the borough level sort of medicines management data can show sort of a continuous pattern. So if we can see a reduction 6 months compared to last 6 months, then that might give us some kind of plausible conclusions.
The data, we could probably look at that change in time, but also if you've done some concerted work in Haringey, we can maybe compare with with the surrounding areas. So if you want if you would share the slides with me, because I didn't see your presentation, I'm so sorry. Happy to look at it with you, because I'm sure you've had an impact with all those SMRs, I'm sure. Well done, good job, by the way.
Thanks, Mandeep. And I think that's all the questions, isn't it?
I think so. I was just going to ask a question. I don't know, were there any kind of specific considerations or challenges into moving things from kind of a discrete project to business as usual?
I think an ongoing challenge is a constant change of priorities in primary care. So every year we have a new contract to deliver on. There'll be different specifications. And actually, the idea behind doing this was to make it as business as usual. And although that's the ambition, you can see we're still closely monitoring to kind of continue the message, to proactively sort of advocate for the work to be done. So I think the constant challenge is having to advocate for it in the first place. And although it's gold standard, it's on NICE, it's CQC, sometimes that's overseen by practices or practice leads and so on. So yeah, unfortunately, I think the way primary care often works is things are prioritized based on these contracts or specific incentive schemes, etc.
Mm. Right. And I just had one other question. It looked like you might have had challenges in doing the structured medication reviews in care homes. Was there any kind of particular learning that you got from that?
We have two major care homes in Haringey, and I think there's a bit of a disconnect, in all honesty. One of the care homes, which is the biggest one actually the medication reviews are done by doctors, not pharmacists, and of course they are fulfilling their contractual requirements to do their ward rounds, which are I think weekly or fortnightly. Although pharmacists are not excellent at coding, perhaps our GP colleagues are even worse. All right. Well, thank you so much for having me, I guess. And if there's any follow-on questions, I'd be happy to, to sort of meet up. I think all the best with your ongoing efforts as well. And thanks, Jess, again for having me.
Yeah, of course. Thank you so much, Shivani.
Thank you all. Bye.
Bye. Yeah, just to reiterate that we will circulate the slides afterwards, so everyone will have a chance to sort of take a look at the presentation in detail. I'm just going to reshare the slides now. So I am going to give a quick MedSip update, followed by an overview of our 2024 and 25 support offer, which was submitted to NHS England a couple of weeks ago. So just as a reminder, or for anyone who's joining us for the first time, UCLPartners is one of 15 health innovation networks in England, and one of 3 in London, which support the delivery of solutions that improve health and care. So MedSip is delivered by the patient safety collaboratives, which sit within the health innovation networks. And the current aim of MedSip is to reduce opioid prescribing for chronic non-cancer pain, as opioids are not indicated for chronic pain, and they pose lots of risks and little benefit, particularly when they're prescribed at high doses or for long periods of time. So this diagram for the print is very, very small, but it shows the whole systems approach to reducing inappropriate opioid prescribing, and it's the role of patient safety collaboratives to support the integrated care systems, or ICSs, to move through the different phases of this approach. So UCLPartners have been working with North Central London and North East London on MedSip. Most of the integrated care systems across the country that have been involved with MedSip will be somewhere between phase 5, which is managing their networks, and phase 7, which is moving from quality improvement to quality control. So I'll summarize our work to date very briefly for the benefit of the newcomers. Our regular attendees will have heard this many times, so I don't want to linger too long on it. But in addition to the opioid network, we have an opioids core working group, which is a smaller advisory group that meets every 6 to 8 weeks. Early on in the program, we carried out a survey with primary care clinicians, and it had a great response rate. So we used some of that insight from the survey to shape our offer for the program. And that included the development of resources for group education sessions to help primary care practices to support patients to better understand and manage their chronic pain and to reduce or stop their opioids if they wanted to. So all of those resources are still available on our website, and they're linked on the slide. We also had feedback from primary care that patients were being started on new opioids in secondary care, but that their discharge letters were missing a lot of the necessary information, including things like an indication for the opioid, how long they had been on it, or a stop or review date. So we worked with Amandeep Setra, who is the medication safety officer at the University College London Hospitals. She is also the chair of the London Medication Safety Officer Network, and she's a member of our opioid core working group. And we created a discharge letter audit form for secondary care. So this audit enables secondary care colleagues to review their discharge letters for a period of 2 to 4 weeks to see what, if any, information was missing from those letters. And the audit form is also available on our website. And a couple of trusts that we've been speaking to and the North East London ICB have run the audits. So we're just waiting to hear their results, which we'll share with this group when they're available. I also held a quality improvement session last January to support any trusts who wanted to take a quality improvement approach to improving the discharge letters in conjunction with carrying out the audits. So the recording and slides from that session are up on our website as well, and linked on the slide. And we also held a Pan London MedSip shared learning event in March, along with 2 other London Health Innovation Networks. So Imperial College Health Partners, which covers Northwest London, and HIN South London, which covers Southeast and Southwest London, as well as with the London Controlled Drugs Accountable Officer, Sarah Demison. So we had presentations on some of the great work that's going on across London to reduce inappropriate opioid prescribing, including a presentation on the UCLH complex pain team from Kelly Corcoran and Jackie Bulambe, and an amazing talk from one of our experts by experience, David Paisley. So this is a face-to-face event, so it wasn't recorded, but we have the slides on our website. And we're hoping to do something similar this year, but we don't have anything planned as yet. Finally, we received the specification for 24-25 and submitted our support offer to NHS England about 3 weeks ago at the end of June. So we shared our draft support offer with the Opioid Core Working Group, which included ICB leads and incorporated their feedback, and just to thank them again for their input, which was really valuable. The support offers are currently being reviewed by NHS England, but we're waiting for sign-off. So as such, I can only describe our planned activities rather than sharing anything concrete, but we are fairly confident that the final plan will look quite close to our offer. So with that caveat, we intend to continue sharing learning via this group, the Opioid Network, as well as the core working group meetings. And we'll also plan to share any learning from the discharge letter audits, as I mentioned previously. And this coming year will be the last year for the opioid program. So MedSip will continue, but specifically the work on reducing inappropriate opioid prescribing will wrap up. So we're planning to do some events on making improvement sustainable beyond the life of the program. We are also planning to step up our patient and public involvement and engagement this year by bringing together a service user group and also appointing a PPIE lead who will act as a liaison between that group, the core working group, and this opioid network. While it is the last year of the program, we still feel like there's ample opportunity for us to learn from our experts by experience, particularly because the local work to better support patients with chronic pain will continue after the life of the program. So we also want to create a more robust way of embedding PPIE into MedSip, which will continue into future work streams. We also plan to create some additional resources in the final year. So the first of which is a primary care QI toolkit, which I spoke about at the last opioid network meeting. This was actually created by another patient safety collaborative, which is Health Innovation East Midlands. But the feedback from this group at the last meeting was positive to adapt it for use in North Central London and Northeast London. So we plan to go ahead with that. Another resource which we're exploring is to create something that we're currently calling a primary care chronic pain support guide. So this was based on feedback from this group that a few GPs are facing particular challenges with a small number of patients who take chronic pain or who take opioids for chronic pain, but who also have other complex support needs. So that might be unmanaged mental illness or mental ill health. They might have dependence or addiction, frequent or unplanned use of sort of different health services, and so on. And the feedback was that so GPs knew that these patients needed more specialized support than what they could offer in primary care, but weren't always sure how or where to refer these patients to. So the idea is really in its infancy, but ideally we'd like to create something that sort of acts as a referral guide for GPs to services that might be national, they might be across London, or they might be specific to that ICB. So we'll keep everyone posted on that as it develops. We'll also continue to offer bespoke quality improvement support for anyone who's interested in doing a QI project related to reducing opioid prescribing for chronic pain. And in parallel to delivering the final year of the opioids work, we're also going to be doing some pipeline scoping for two potential new programs. The first of which is psychotropics with people in with learning disabilities, and the second is falls-inducing medications and frailty. So this will initially involve some stakeholder mapping in both of these areas, followed by scoping interviews. So I might reach out to some of you in the next few weeks. So what the programs will actually look like will depend on the kind of analysis and the results of these interviews. But again, we'll share any details as they become available. Dana, am I pronouncing that right? Would you like to come in?
Hi, thank you for that. I just wanted to ask, in terms of quality improvement support, so I work at Barts Health NHS Trust. We're looking to do something in quality improvement. Is there an email address or something that we could contact you guys with just to get that support, or?
Yeah, so I'll drop my email in the chat now. So when I did the session on quality improvement methodology relating to the discharge letters, it was kind of a general overview using discharge letter audits as the as kind of a running example, but a lot of the kind of similar principles were there. But also UCLPartners has a free online QI training, so I can send you the link to that as well. And then if you want any kind of specific support, you can reach out to me.
Thank you, that's really helpful.
No worries. Okay, well, we absolutely blazed through the agenda. So I wanted to leave enough time for discussion if there was any questions about, particularly about Shivani's presentation. But if not, I am happy to give everyone a half an hour back into their diaries. So yeah, as I said, I'll circulate the slides. Afterwards, there are links in the slide deck to a lot of the things that I've mentioned. But yes, please don't hesitate to get in touch with me if you have any questions or any thoughts.